Hey, deserving listeners. So last year, just over a year ago, I was at the Washington Association of Marriage and Family Therapy Conference here in Seattle. And there were a lot of really great classes I was taking. I was meeting a lot of people, meeting a lot of old friends, a lot of old colleagues, seeing some old alumni, some graduates from the program. And I also went to at conferences, if you're not familiar, professional therapy conferences, there's often a room or a hallway or something where people will be presenting their research on what they call posters. And they are, related to either the topic of the conference itself or just therapy in general. And it's typically grad students or recent postgrads who have conducted some sort of research and have put together a poster. If you're not familiar, think about fifth grade science fair, where it's an elementary school and some kid has a overflowing lava volcano and another kid did some sort of research about different dogs in the neighborhood. And it's similar to that, except obviously more rigorously scientific and often represents hundreds of hours of work on behalf of the student or the grad. And since research is often chosen with care and with passion in an area that student is passionate about, it's a really great thing for me to go up to these different posters, because the presenter is usually standing right there, kind of eagerly wanting to talk about their research and hoping that someone will come up to the poster and say, "Tell me about your research." I mean, that's the whole point. They're there. And then at the end of the day, there's a award that is typically given out to the best poster or something. And so there were a number of Antioch students who had posters a year ago. And one of the posters, or actually two posters, I was fascinated by. One was by Yolanda Christensen. Hers was on the issue, and I had her on the podcast, 6 months ago, about kids or teens who are heavily involved in sports, and they exist in a culture of heavy involvement in sports. Their whole life is like softball or soccer or wrestling or track or gymnastics or football or something, and then they have an injury and it's this huge loss. It's just this mammoth change in their life. They might not ever be able to play like they did before, and their life just completely takes a left turn. None of their friends are the same. None of their life goals are the same. Everything gets thrown apart there, and me and Yolanda talked about that. Well, another poster that I asked to come on the podcast a year ago was Idil. She was a supervisee of mine. She's a recent grad from Antioch and a marriage and family therapist. And her poster was on painful sex and a particular condition that we'll get into in a second. And not only was it interesting to talk with her about it, but someone had emailed me just prior to that conference, a listener, a patron perhaps, asking me to talk about painful sex and what that's like, and maybe some considerations for people, what to do, maybe to destigmatize it, allow people to talk about it, this kind of stuff. And so I asked Idil to come on the podcast a year ago, but I think it took her this long to get up the nerve to come on the podcast. Welcome to the podcast, Idil.
Hi, thanks for having me.
Sure. So you spell your name Idil, and it's Idil. Mm-hmm. And your last name is spelled?
Levitas.
Livatas. Right off the bat, where can people find you if they wanted to hire you as a therapist?
So I work at a small group practice called Modern Therapy Seattle, which is in Seattle, in North Seattle. They're welcome to email me or go to our website.
Okay, Modern Therapy Seattle. Go to the website. Idil, you want to hire her if you like her here. I sometimes get people asking me for referrals in the area, and you're on my short list of people that I refer to. We've had other people from Modern Therapy Seattle, namely the owner, Kate. She is Stewart. She's been on the podcast talking about her open relationship handbook and about flirting. She had a flirting class a long time ago. She's also an Antioch grad herself. So let's talk about painful sex. What was your poster about, Idil?
So my poster is about a specific vulvovaginal pain condition called provoked vestibulodynia. It's kind of a mouthful. And one of the reasons that my poster is on this particular pain condition is that it's the main cause of genitopelvic pain or penetration disorder, which is a DSM-5 disorder that was added. It combined a couple disorders in the DSM-4. So as I started learning about painful sex, I found out that, I call it PVD for short, that PVD is one of the main causes of painful sex and of this disorder.
So it's in the DSM, which would imply that or require that it has some psychological component. Is that what they're saying?
Not exactly. So yeah, it's kind of a strange DSM-5 disorder in that it's saying, this is a disorder that's very physical. The criteria in the DSM-5 is, pain with attempted or with intercourse, or fear of pain, or just inability for there to be penetrative sex at all, vaginal penetrative sex.
Okay, so let's go through that a little bit. So the criteria are if you are having pain during intercourse. So this is all intercourse space.
Yeah.
Vaginal, do they specify heterosexual? Because, there could be lots of different kinds of things happening.
No, they don't. It can be for anybody with a vulva and vagina.
Okay.
And they say, this is a disorder that only applies to females. I'm trying, to be careful about how I talk about it, there's people that don't identify as women who have vaginas and vulvas, and, mostly it's women who are coping with this.
Okay. So people with vaginas who are experiencing pain during some form of penetration, whether that's with a penis or a finger or a
toy of some kind.
Or a toy or something. And they are a lot of pain, right?
Yeah.
And not just like, oh, that was a spot I don't like to be poked. Let's avoid that spot. It's like pain. Is it pain everywhere? Like how do people describe it?
So the DSM-5 disorder is sort of a catch-all for a couple different things. So it can really vary. So, so there's something called vaginismus, which was in the DSM-4, which is mostly about internal muscular pain inside the vagina. And then vestibulodynia, provoked vestibulodynia, is very topical pain in a specific area of the vulva, right around the opening to the vagina. And then the DSM-5 disorder also says, maybe there's not pain, but there's just fear of pain. Maybe it's just someone saying nothing can go in, and there's not actually pain. It's just not a possibility for there to be penetration of any kind. So it's really, my understanding is that the DSM-5 version was created to kind of acknowledge that maybe there's a spectrum and these, various pain conditions are connected, and they're often comorbid. So somebody who says, I have vaginismus, nothing can go in, might also have topical pain. But there's also these distinctions between them. It's a bit confusing.
So I don't know anything about this.
Okay.
So my language might reveal that. The spectrum you're talking about, are you talking about a spectrum between vaginismus and the new diagnosis?
More like there's a spectrum between, there might be, and this is just an idea, there might be a spectrum between like topical pain and internal, pelvic floor muscle pain.
When you say topical pain, are you talking about opening pain?
Topical meaning on the vulva, not inside the vagina.
Inside.
So the topical pain that people experience with PVD, for instance, and that's what I'm referring to, is really pain at very specific points, right on the outside of where the hymen meets the inner lip.
Okay. So some people experience pain more on the outside and some people experience pain more on the inside.
Yeah. So the outer pain that's right around the opening of the vagina is what provoked vestibulodynia. It used to be called vestibulitis, meaning like an issue of the vestibule, the entryway to the vagina. And then vaginismus, which is research shows it seems like it's less prevalent. Maybe 6% of the population has experienced this either inability to have something inserted into the vagina or, or just fear and this sense that that it's just not an option.
Right.
Whereas when there's topical pain, there is still an option for penetrative sex to happen. It's just gonna burn and sting. I think of it as, if you imagined a band of muscles that like a rubber band being an open wound, and as it gets stretched, salt being poured all over that rubber band as it stretches.
Ow.
Yes.
Yeah.
that might be people's experience.
And it sounds like you're saying not an option. What I'm hearing you say is that the idea of theorists or clinicians that work with this sort of thing. Do you work with this sort of thing? Do you have clients with this sort of thing?
I have had a few.
Okay. That the idea is that for some people, they have a functional biological condition that leads to pain, right? There could be some kind of injury, or I'm not a biologist, so some kind of abnormality, shall we say, of maybe a small opening or sensitive nerves on the outside, or something that what we would typically call, if we're going to do the split between mind and body, which is a little silly, that it's a body condition and not a mind condition. Mm-hmm. Mm-hmm. And then on the other end of the spectrum, there are people who don't have any functional biological body, if we're going to separate mind and body, problem, and they have either from trauma or from anxiety or a compulsion that they are worried that there's going to be a problem, and that makes it so that they either psychogenically have a pain, or it causes them to not be aroused because they're so afraid that they experience pain when they try to have those kinds of sexual experiences. Is that, you're making a face like that's
I don't think that's quite it, but honestly, my research isn't on vaginismus, the one where, people will say it just doesn't go in. So I don't know as much about that, but I do think there is a real physical and muscular issue happening. It might just be that the presenting problem is more fear than, maybe there's no attempts. So they don't, maybe a doctor doesn't have the information on like how severe is the muscle tension because someone's just saying, no, I'm too scared to even attempt this.
Well, of course, it's going to be painful. So that's rational fear, right?
Yeah. Yeah. And that's actually something that I think a lot of people have experienced is, when you just do, pelvic exam, or, there's a pain test with a Q-tip for provoked vestibulodynia, the vulva looks normal. And if, someone looked, was able to get a speculum in, it's going to look normal. So lots of people in the past have had the experience of being told like the pain's in your head. It's not. So yeah, if I, was confusing about that, it's definitely not in people's head. It's happening. And,
so the condition your poster was on is something that is considered to be a biological condition that you can have a psychological reaction to.
Yeah. And they're so connected that it's hard to even tease it apart that much. So there's a biological, process happening where basically there's an issue with the signals from nerve endings and what they're sending to the brain. There's also more nerve endings firing than for somebody with PVD than someone who doesn't have it. There's also more white blood cells at the areas where the pain is.
Do they know why it happens?
Not not really. I mean, there's some ideas, but
yeah. So I'm not a biologist, as I've been saying, but from biologists that I have listened to or read, it's sounding similar, and correct me if I'm wrong, to things like IBS or...
Yeah, and there's connections actually. So like often people who have IBS or fibromyalgia or TMJ, which is like a jaw issue, will also have PVD.
Interesting.
Yeah.
And there's, with IBS, certain conditions of the body really lend themselves to our ability to figure out what's wrong, like a cavity, for example, or even something like Alzheimer's. When, you know, post-mortem, you look at the brain and you're like, oh, there's like dead tissue, or there's pathological tissue in the brain that must have resulted in this memory problem. But when it comes to IBS and when it comes to fibromyalgia, it's hard for them to identify something, you know, the cause of it. And even when they do narrow down cause, it seems to only apply to some of the people. And a lot of the things like increased white blood cell count, increased nerve activity, that can be a secondary thing to something else that can actually be psychogenic. You know, like when I'm stressed out, my bowels aren't going to be working as well.
Right, yeah.
So it's possible I could induce IBS temporarily for me if I was freaking out.
Right.
But the chance that that's the only answer, right, is in terms of observation, it doesn't seem to be likely.
Yeah.
Also, we have this cultural thing around like, well, it's all in your head, as if it's your choice or you're a weakling or something.
Yeah.
And that's why, like, you know, I don't want to separate the mind and the body. It's like, to me, if something's in your head, okay, great. It's still horrible. You know, it's still painful, and it's still debilitating, and there's still stigma, and there's still like no help out there, and there's still no answer to that. You can't just say, okay, stop thinking about that, you know?
Yeah.
So anyway, but from the sound of it, it sounds like the researcher is saying there seems to be something different about some people in terms of their biology.
Yeah.
That is elusive to our current scientific technologies. And it might be a number of conditions that result to this. This can cause from what I know about IBS, because the gut, they call it the gut-brain system because it's serotonin is in the gut. Like when you take an SSRI, you can get constipated. If you think about it, we're basically just walking guts. like our muscles are on our bodies to get us to things so we can shove it into our mouth to make things go into our gut, you know?
Right, yeah.
Like everything we do is designed to get stuff into our gut. And so it just makes sense that our primary sort of axis is our brain-gut system.
Right.
And so when we have complications there, it involves psychology. It's all like, you know, intermixed and stuff. And so, of course, with sex and culture and intimacy and attachment and past experiences with the pain, and it's going to cause like just an evolving syndrome over time. But I'm still sort of baffled as to why it's in the DSM. You know, it's like,
yeah. Well, and it just seems like that's part of like what's so odd about the DSM is that some medical issues make it in where it's like, well, when this causes psychological distress, then it's a disorder.
But
in the
cancer
DSM.
causes psychological distress.
I know, yeah.
So,
it is very strange. I mean, maybe, I guess the nice way of thinking about it might be that it's a way of recognizing how many people are coping with the distress of this, you know, of pain during intercourse. Maybe that's why it's in there. It is odd.
I have no idea, but I would suspect that there are people who think of it, since it's unclear, they think of it, at least for some people, that it's at least partially psychogenic, is what I'm thinking the DSM writers are saying, because otherwise it wouldn't be in there.
My hope is that with it being in the DSM, maybe, more clinicians and students are going to be exposed to at least having a general sense that this is something people are struggling with and coping with, and that there's a place, for us to support them in having a more satisfying sex life and, it not impacting their relationship.
Right.
Which is actually mostly what my poster was about, which was that, like so many medical things, just addressing it as a biological issue leaves out all these other ways that it's impacting people's lives. And there is, really pretty good medical treatment for PVD. And the outcomes that are measured is there a decrease in pain during intercourse, which makes sense. But what's getting left out, right, is like, how is sexual communication between the couple? Because it, maybe got really hard, while they were coping with this at its worst. How's relationship satisfaction? How are people's depressive symptoms? These are all things that, PUD correlates with pretty negative outcome measures.
Yeah, I mean, people in our society in general are, because our society is so Victorian and backward when it comes to sex,
right.
It's really hard for people to know what to say or to feel confident to say things or feel comfortable having conversations about such matters, even if they're good things, let alone tense things like, hey, when we have sex, it hurts.
Yeah.
And so let's just take a heterosexual couple as an example. The wife is just hurting, and let's say she also has been having some libido problems, which would make sense given the fact that it hurts.
Right.
And over the past couple of years, the husband's been like, we don't have enough sex. And she's like, oh, okay. And maybe it's in my head, or maybe I shouldn't be married to him. Maybe, because with my previous partner, it wasn't this bad or something, there's all these thoughts that run through your head. And then you sort of endure it and it's painful. And maybe even you're just laying there as a woman, just like, okay, I hope this ends soon.
Right.
Because I want him to be happy.
Yeah.
But then he's like, this isn't any fun. She's just laying there.
Right.
And it's over. He's upset. He walks away. She's crying. What do you do?
Gosh.
And then it's just like, this could have all been helped if our society wasn't so fucking stupid, and could just be like, hey, so I want to have sex with you. I like having sex with you. And it hurts. I don't know why. Maybe we should talk to someone about this. I'm sure it's not you. I'm sure it's not my fault. I know that, because I have confidence, and society hasn't taught me that all my problems are the women's fault in sex. It's like, we live in a wonderful society, and I should be able to just admit that, ow, this hurts right now. Why does this hurt? Let's figure this out, because boy, do I want to have sex with you all the time, and I don't want this getting in the way. Could we stop having sex this way? Maybe we could do
that would be so awesome. Yeah, I love you painted that picture of how it could go if everything was different, right? If the patriarchy didn't exist. Yeah, and you actually pinpointed a lot of the issues that come up for women. There's been a qualitative study done that showed that, a lot of people's reasons were like, I don't want to lose my partner, so I'm going to have sex anyways. Or, sometimes even young women not knowing, or inexperienced folks not knowing that sex, isn't normally this painful, and thinking like, well, maybe this is just what it's like. Yeah. And one of the things that I was really interested in is, okay, so we know there's good medical treatment. We know that couples are getting impacted, and the individual, mental health.
What is the medical treatment?
There's a bunch of options, actually.
I assume like lube is like something to try for some people right off the bat, right?
Yeah, totally. Because friction is going to make it worse, for sure. Friction, pressure, and pressure basically are the things that hurt.
So like maybe not as hard sex or something? Or smaller things? What do you mean by pressure?
Yeah,
exactly?
Well, just even so the assessment, the medical assessment to diagnose people for this is the pressure is just a Q-tip pressing pretty gently on specific points. So even that pressure, or the stretching open of the vaginal opening.
So there are, what I'm hearing, gynecologists who specialize in this.
Yeah.
Who have a series of tests that they run, and they probably have like a scale, like Q-tip pressure 3.
Yes, exactly.
No response.
Yeah.
Pressure 5, mild response. Stretching of opening 1 centimeter, response. There's different tests they do to see like what causes the pain and that kind of
Right. And the Q-tip test on the vulvar vestibule is the main one for PVD. And then, sometimes, putting a speculum is an option. Sometimes it's not, depending on the severity of the pain.
How do those people get through pap smears?
With great difficulty, I think. And
is that the point when the physicians often hear about this sort of thing? I mean, are physicians the main people who hear about this condition?
Yeah, I think people seek medical treatment first, and then, go through seeing many, many people before they get an accurate diagnosis. They might not get one at all because it's actually not, something most gynecologists might even know very much about. Although I think that's changed quite a bit in the last, 5 to 10 years, but they still might not really know how to diagnose it or what treatment is. And I know you asked about treatment options, and there's a few different ones. There's topical medication that basically is rewiring the signals your nerves are sending to your brain.
Like a steroid or something?
Yeah. Well, actually, maybe. But no, the main things are, a numbing cream.
Okay.
So it's actually, changing that response so that you can't experience as much pain. And then there's another medication that does the same thing. It's similar to it's the same thing that's in seizure medication. So it's actually like slowing down.
And that's topical too? Or that's
so that will be a topical medication too. The physical therapy is often a really big component for people that also have muscle hypertonicity, which, is just muscle tension.
Like everywhere?
No, it's physical therapy for pelvic floor muscles. So
like Kegels and all that kind of stuff.
Yeah. So like one, course of treatment might be just doing physical therapy where you have, I think you mentioned this, increasing sized dilators, being used to like help relax the muscles and practice relaxing them more and more. Yeah. And Kegels. And then there's surgery as an option. I don't know that much about that. I know.
Would that just be like cutting the nerves or something?
I don't really know. Much about the surgical
Would Botox
option.
be a thing? Because Botox.
Yes.
Okay.
And then, on our side of things, the treatment that is helpful is CBT and mindfulness practices and integration of those things.
Specifically, like what would you do with CBT and relaxation, that kind of stuff?
Well, I think in terms of CBT, one of the most important things that I think we can help clients understand, similar to any, phobia, is that there's this connection, there's this fear avoidance cycle that will develop because of the pain. And I think clients don't always know that they're kind of helping maintain both the pain and just nothing improving. So, as somebody's nervous and anticipating pain, they're probably not going to be super physically relaxed. So if they're tense and then have sex anyways, it's more likely that the pain will be worse. It's definitely not going to be less.
Right.
And then, with that comes this, can come pain catastrophization. So it's, helpful to educate people about that and kind of change those automatic thoughts of expecting it to feel really terrible. And there's this, I'm sure as this like hypervigilance that can come with like monitoring, the sensations in your body. The other thing I was thinking about is just that you mentioned earlier is like this scenario you painted of how badly things could go for someone, is that one place that is sort of kind of where it'd be great for there to be more research, and it's starting to happen, is on, where does the partner come in and how can they be integrated into treatment?
Right, because that's what your poster was about, right?
Yeah, mostly. And, how a partner interacts with someone in that moment where they're like, I'm, feeling pain or nervous about feeling pain can make a really huge difference. So a lot of the research I read was about how important these responses are in a moment of pain. Let's say, someone winces, right? There's 3 general ways somebody can respond. One is negatively, which is basically what it sounds like. Either like being hostile or acting, seeming frustrated. And then there's solicitous responses, which looks very nice. Might be like, hey, it's okay. We don't need to do this. Like, do you want to finish that movie we were watching? And then there's facilitative responses, which are being like, okay, like maybe we can shift positions. Why don't we do something else? Let's try and figure out, let's focus on what feels really good and find a way to do something less painful, but continue sexual activity.
Or be open if that's what the person wants to do.
Yeah. In a non-pressuring way.
Right. The soliciting sounds like overreactive or something, or too nice, or I don't know.
Yeah, it's really nice, but also feeds into this fear avoidance cycle where it's like as soon as something, hurts or is scary, we're going to stop.
We're going to run away.
Yeah.
Yeah. And the first response, just to elaborate on that, is quite common because for men, if we're sticking to heterosexual couples, men are taught that, women are supposed to just be infatuated or just head over heels with everything sexual about a man. Like the man is supposed to walk into the room hairy chested and mustachioed like the late great Smokey and the Bandit. You're supposed to just, I'm going to have you, and you and the woman's supposed to be, this is the movies.
Right,
it's
right,
like, oh my God, you're the best lover. You have the biggest penis.
Right.
You can last all night. Every other man has paled in comparison to you. This is, I can't even, I want it all night long.
Right. Even though we haven't talked about what we're into at all, it's just going to go amazingly.
And even though, you're a 22-year-old, bare-chested, non-mustachioed guy, and you know nothing about sex and except for what you've seen on the internet, and, God knows what that's taught you.
Right.
And so, and yet that's the duality that's happening in the man's mind. And so as he's having sex with a woman, even if it's, 10 years into a relationship, it's the same. It doesn't go away. It's not like masculinity fades, It's just like it's in some ways it gets more intense because you're potentially not getting the gratification of what dating can provide. But anyway, so then you're sitting there and you're just like, okay, I really hope that, this is the most amazing sex she's ever had in her life. This like every time has to just be, I just have to give her the most amazing.
Yeah, there's so much pressure too.
Yeah. And then she winces, right?
Yeah.
And you can tell she doesn't want to reveal that she's winced. It's sort of like when I'm at the dentist, I have these front teeth, my front lower teeth. Every time I go, do you have this where I have so much tartar on my front lower teeth, just the first 2 middle teeth. They sort of breeze over the molars and everything else. And then they get to these 2 front teeth in the front because I have like salivary glands right there or something.
Yeah, and they're like these ones.
It takes them like a half an hour, I don't know. And it hurts too because they're really just jamming in there, I don't want to hurt her feelings because I know she's trying she has a job to do. She can't not do it. She's got to do it.
Right.
But it hurts intensely. And I'm trying to like go,
right. Just bear it.
Yeah. But sometimes I wince and she can sort of see my eyes sort of clench underneath those really dorky sunglasses they give you.
Yeah, they're
like,
huge.
You're like Terminator, you know what I mean? I'll be back or whatever. And so, she's trying not to reveal because she wants it, because she has all these messages too, like you have to be a vessel of sexuality for him to enjoy himself. And, you're supposed to be into it all the time as well. He's supposed to be amazing. You're supposed to be a vixen, blah, blah, blah. So she doesn't want to reveal, but then, so he sees that face and he's like, wait, so behind this very thin veil of fantasy that I'm the most amazing sexual partner she's ever had, she's trying to, a little bit of communication was emerged behind that. then, crestfallen and hurt and like shame and what's wrong with me? What else has she kept from me? Like it's a flood of pain and hurt. And then depending on how you cope with such things, you either say like, oh, what's wrong? Is any, if you're secure or you've been taught how to function in such manners. But more than likely, you're just going to be like, oh shit, just a freak out thing. And you'll either avoid by doing the soliciting, or you'll get hostile. You have a negative reaction and just be like, what I do? It's your fault. You're not relaxing, or, or like, you're just a cold fish or something, or I don't know.
Yeah, something really unkind.
Yeah.
Yeah. And I think, for, partners who are very respectful and really care about their partner and don't want them to be in pain, it really makes sense that they might end up providing these solicitous responses, because they don't know that there's this option of a facilitative response, and like they don't know how to figure out what the line is necessarily between, encouragement and pressure, because, lots of men, they're like, I don't want to do anything that pressures this person actually. So I'm just gonna be like, it's in your court. Whenever you want to stop, we can stop. And if somebody's in that fear avoidance cycle, it's very likely they're going to be like, okay, let's stop. Like it started hurting, let's stop.
So there's two types of that I could see happening. One is a genuine, the ball's in your court. I'm cool. I'm cool. Mm-hmm. Like they're cool externally and internally. The other one is a passive aggressive, I'm cool, of just like, hey, the ball's in your court. But in the man's mind, he's just like, she better fucking she better pursue me, or else I'm going to punish her for not doing her job in the marriage or something.
Right. Yeah. And that's where I think, it's really clear that there's all these places that a couple therapist, can play a really useful role in helping the couple see this as, it's not just her issue. Like this is a problem that you as a couple are coping with, and, and that he or, whoever, or the partner is also being really impacted. Like there might also be, a big sense of loss or disappointment or grief, for the male partner too, or the, or not male partner. I know we keep talking about heterosexual couples, and that they probably aren't going to find anywhere else that they're going to get support for that.
Right.
Maybe even more so actually than the person with PVD, because at least, for people who are, female socialized, we talk to each other about sex, about feelings and relationships in a way that, male socialized folks that's not an option for folks as much. So I could see for partners this actually being just as isolating and difficult to cope with as for the person that has it. The treatments can be very successful for PVD. When I looked at it at the, meta-analyses, it was like, oh, wow, there's actually a lot of great options that most folks don't know about, unfortunately. And at the same time, the CBT, treatment manuals on how to do CBT for PVD, will say like, make sure, you're helping people understand this might be a lifelong condition that they're learning to manage, and how to have, a satisfying sex life in spite of the pain. For some people, it might go down. For some people, it might be very similar for most of their life. Yeah.
Okay. So what haven't we hit on yet that you wanted to talk about? That was your main poster, was couples therapy regarding this condition and hope for the future, that kind of stuff, right?
Yeah, I think, if this comes up for clinicians, if they're seeing a couple or an individual who brings this up, I think one thing that's kind of unique to the role that we can play that's worth mentioning is that I think there's a place where the therapist can kind of help coordinate care, and be a place for that person to come back to after they've gone and gotten a medical diagnosis, and a place for the partner to get included in treatment as well.
Yeah. Well, thanks for coming on the podcast to talk about painful sex, Idil.
Yeah, thanks for having me.
I think it's an important topic that is almost never talked about. And I think way more common than people think it is. And even if it's just slightly common, I think those people need more contact with people like you who can help them out with that. Take care of yourself out there because you deserve it. You really, really do.